Buenas noches,
Good evening.
muchas gracias a los organizadores
And I want to thank the
el Día Mundial del
organizers
Pulmón
of
Crítico
the World
por
Critical Lung
invitarnos
Day
nuevamente a estar aquí.
for inviting us to be here again on behalf of the Spanish Society of Critical and Intensive Care and Coronary Units. We will have a session on updates in acute respiratory insufficiency, and we will focus on the release of mechanical ventilation. We have members of our acute respiratory insufficiency group, some young ones, some with more experience. And they will talk about a very interesting topics such as cardiopulmonary interactions during weaning, new failure models for extubation, and finally, what is new in weaning. We will slightly change participant order. We will start with Dr. Patricia Rodriguez from the Toledo University Hospital, Toledo, who will talk about prediction models for the failure of extubation. Patricia, thank you for that introduction. Thank you for the invitation. And I will start by sharing my screen. My name is Patricia Rodriguez. I'm an intensive care physician, and I will speak about prediction models of failure of extubation. And the first question that I want to answer is if it makes sense to predict failure of extubation. And we will go 10 years back to think about how we predicted weaning of patients, where we did it in only 2 steps to assess through screening patients that are prepared to go towards the weaning process and confirm it through a spontaneous ventilation test. But in the last 10 years, there's been a development of a research and work line related to prevention of post-extubation failure with respiratory support. And that has opened an important pathway to talk about prediction of the risk of failure. So yes, answering the question, it makes a lot of sense because it will be the prediction of the individual risk of failure to look at the most adequate preventive therapy, not only the preventive therapy, but it will modify the way in which we screen and the confirmation through the spontaneous ventilation test. So I will look at the failure of the risk of failure, and I will ask, what happens if we fail with the risk prediction? On one side of the scale, it could happen that we do not detect patients at risk, so we're not taking advantage of the opportunity of preventing the failure and the need for reintubation. We're losing that opportunity either because we haven't used any therapies or because we have chosen the wrong therapy. On the other side of the scale, we would have what would happen if we fail because we overestimate the risk. So that would mean we use excessive preventive therapy. In a pragmatic sense, it doesn't seem to have an importance in terms of adverse effects. No large papers on adverse effects. But if our problem is resources in the unit, and overestimating the risk would have us use the resources incorrectly. Regardless of what we do, if we use therapy or we don't do it, what will be especially when there's a delay in the reintubation of our patients. So it's one of the most relevant aspects that we need to consider. Well, let's speak about the world of failure.
We have several functional predictors prescribed as a result of weaning invasive mechanical ventilation. Some of them are complex and unapplicable at the bedside. When we see some of them, we see positive verosimilarity, low, and in the parameters in which we have higher ratios, there are few trials and very disparate trials. And these predictors I am telling you about will show the possibility to change from a spontaneous ventilation test successfully into extubation. So for we cannot move forward in planning a prevention strategy according to the risk of our patient, the screening process, and the spontaneous ventilation test. So these are somewhat limited. And when I say that prevention has been developing its own pathway, and hand in hand with prevention prediction. We have a couple of risk factors, some of them related to the patient age, comorbidities such as the heart, the lung, some associated to the critical pathology, neurological problems, Apache score, severity of the critical disease, Weaning itself, and functional parameters of which we mentioned before. What have researchers that have developed these strategic prevention lines done? They have developed models to assess risk factors. For instance, the 11 factors model of Dr. Gonzalo Hernandez, which keeps into account age over 65, comorbidities, cardiac and pulmonary, severity in terms of Apache score, the type of weaning, comorbidities, assessment of strength to calve and move secretions, the risk of a stridor, obesity, and the duration of invasive mechanical ventilation over 7 days. But on the contrary, we have other more pragmatic models, the French Arnoldo model, which uses three key aspects: age, 65 years, cardiac comorbidity, and pulmonary comorbidity. So we decided to consider another model. We generated a 4-factor model which combines the 3-factor models, and we are going to introduce one additional item which we consider key in the 11 factors model, and that is invasive mechanical ventilation for more than 7 days. And the first question is, why do we consider that this item is key? Well, because it speaks about two important aspects. Number one, muscle weakness developed in the ICU. If the patient has been connected to mechanical ventilation for over 7 days, this muscular weakness develops. And it also speaks about the 7 days of invasive mechanical ventilation. And we analyzed the 3 models and we published it in Intensive Care Medicine early this year. It's a 5RST post-op, a population with risk of failure of extubation, very heterogeneous. We are going to stratify it with 3 factors, 4 factors, and 11 factors. The primary goal is re-intubation for any reason. And we are going to assess that re-intubation in the first 7 days after extubation. Because we know that post-extubation failure, when we use a preventive support, may reduce the clinical expression of the post-extubation failure. So our experience must expand, and the limits that were 24 to 48 hours are now 7-8 days. The secondary goal, which is relevant later on, is the reason for reintubation. Let's see the behavior of our models first. How about the detection of high risk of failure of extubation? As expected, the complex, exhaustive, detailed model of 11 factors managed to identify more high risk of failure of extubation as compared to the 4 and 3 factors model. Similarly, when we assess how it detects the low risk of extubation failure, the 11 factor identifies less low risk, whilst the 3 factor detects more low risk. Let's analyze the data. Let's see the patients that were established as low risk according to the 3 factors model. They were re-stratified as high risk when using the 11 factor and the 4 factor model, because these 2 models are more complex and more comprehensive than the 3 factors. Therefore, it's more likely that patients are classified as high risks. But probably this is the surprising data. The patients classified as low risk by the 11 factor model were re-stratified as high risk by less complex models, for instance, the 4 and 3 factor models. And this is interesting because it is explained with collinearity. When we have independent variables in the same model, they will contribute redundant information that will reduce predictive ability of the model. We have seen that Charson was going to score in an 11-factor model according to the comorbidities of the patient. But in the 11-factor model, we also have specific items to analyze: cardiac comorbidity and lung comorbidity. Not only that, in the Apache score as a marker of severity of critical disease, Age also counts, and age is another independent variable which is present in all models. So this combination of variables in the same models reduces the predictive ability and explains that surprising data. Let's see the behavior of the models with regards to risk and reintubation. The 11-factor model, which predicted a high risk, in that population of high risk, they required reintubation in up to 84% of patients. So it was right, high risk, they were going to be reintubated. But look at the group of patients with low risk. In fact, since the risk is low, there were not reintubated in a large proportion. Only 15.8% of the patients were reintubated. But with the 3-factors model, it said that 1,016 patients had a low risk, and however, they required reintubation in a high percentage, 37%. When analyzing and comparing the diagnostic accuracy of our models, we must use valuable data. Models perform well in terms of sensitivity. I like to speak about negative predictive value because this is its clinical application. When our models tell us that our patients have a low risk of failure of extubation, I will believe that because most likely they won't require reintubation. The problem comes when the models tell us that the risk of failure of extubation is high, and this has to do with specificity and false positives in our models. All models have positive predictive values which are very low. That means that I believe a lot when they say that the risk is low, they won't be reintubated, but when they tell me that the risk is high, there can be an overestimation of the risk of failure to extubation and the use of preventive treatments. So we have seen the behavior of our models, and now let me understand why. There are interesting considerations in this regard. In this study, we made an analysis of all the variables that develop with post-extubation failure. And in the 11-factor model, everything was related to failed extubation except the risk of a stridor. How come that the stridor risk is not associated? Let's analyze that. But before that, let's look at the secondary objective, the reasons for reintubation in our cohort. 23.5% of the patients required reintubation because of non-respiratory reasons. Need for surgery, coma, not secondary to hypercapnia, it was not respiratory, and 19.5% had respiratory failure related to the airway or poor management of secretions. So only 57% of the patients requiring reintubation was because of failure in removal of the ventilatory assistance. But being fair with our models, their predictive capacity is only based on the detection of that respiratory failure of weaning. They don't have an ability to talk about non-respiratory causes or the airway. Not only that, when we speak about predictive capacity, when we speak about positive and negative predictive values, it is necessary to take into account the prevalence of the factors we want to predict. This is the cohort of the study I presented. In this cohort, the alteration permeability of the upper highway was only present in 6% of the patients. And it was not statistically significant. On the contrary, management of secretions, 14% prevalence, and it was statistically significant related to reintubation, but the odds ratio is very weak. This is surprising. Why? When you look at the bibliography, the largest biography, for instance, Epstein in 1998, found a prevalence of failure as a result of the upper airway of almost 31%. Other authors, such as Laver in 2018, identify a prevalence of up to 50%. Therefore, it seems that in our cohort, Respiratory failure related to the upper highway was not well represented, and this may explain why it didn't have the statistically significant relevance. So to be fair, our models have a low global predictive capability. This is true. But in part, that is the case because they are looking for prediction on a very low percentage of failed weaning. They only do it in failure of ventilatory support. The paradigm of weaning has been expanded. Now we speak about other key factors, and each one of them has an influence on the next, particularly at the end. So we wanted to see whether the changes in these different aspects had any impact on prediction. We started with screening, and in screening, we did not find any association between the type of screening and the development of post-extubation failure. So we were not able to adjust our models to screening, but the use of post-extubation therapy, respiratory support therapy, was related to a reduction in failure. What happens is that due to the logic, we did not correct our models in terms of the post-extubation support because that would introduce bias. It helps to predict post-extubation failure, but we cannot correct our models based on that. Why? Because obviously patients at higher risk are the ones that are going to use more respiratory support. And finally, the type of a spontaneous ventilation test to be used to confirm that the patient is ready for weaning. And here we obtain interesting data. With the exception of the 5-0 test, the other tests, which were 7-0 and 8-5, were related to a higher proportion of weaning failure. But when we corrected our models, adding this consideration, we didn't improve the predictive ability of any of our models. When I think about weaning failure as a main concern, I think I have to consider the differential diagnosis, which is very broad. And I think that one single parameter cannot represent the complex reality of weaning failure. Therefore, individualized means careful care. Each one of our decisions will involve other decisions of other aspects participating in the weaning process with regards to the individual prediction of failure. 3 and 4 factors are similar. So today I would use the 4-factor model. And this line to establish individual risk prediction and preventive therapy. This is a key line. One of the authors that has developed this the most is Gonzalo Hernandez, and I am sure that we will get more information in the future. Thank you very much for your attention. Thank you, Patricia. Questions are at the end. I will now give the floor to Ana Maria Diar from the University Hospital Fundación Jiménez Díaz. She will be speaking about cardiopulmonary interactions during weaning. Good afternoon, good evening. I will proceed to share my slide. Once again, thank you for the invitation. The topic of my presentation is physiology and pathophysiology of cardiopulmonary interactions during weaning. I will consider 9 different items, but I will do that quickly, so don't be afraid. I will be speaking about the weaning concept itself, the physiology of cardiopulmonary interactions during mechanical ventilation, and then specifically during weaning, risk factors, of which Patricia also discussed. What kind of spontaneous ventilation test is better? Which are the mechanisms behind the failure of weaning? How can we develop an individualized therapy, and then some practical algorithms? And finally, the take-home messages to use in our clinical practice and continue studying. Weaning is important. As we already heard, the days of mechanical ventilation increase mortality, and failed weaning also increases mortality. It's important because it's multifactorial, and therefore it is difficult to identify, and also because in high-risk patients, the failure of extubation is twice as high. As we saw in this diagram of one of the articles regarding long, hard interactions, we are going to focus on the impact of mechanical ventilation on the cardiocirculatory and respiratory systems. In positive pressure ventilation, insufflation during inspiration reduces the preload of the right ventricle due to increased intrathoracic pressure. And on the other hand, there is a slight reduction in the post-load of the right ventricle. This is due to the reduction of transpulmonary pressure. During insufflation, there is a decrease in the right ventricle filling, and therefore a reduction in the cardiac output of the right ventricle. And this will be reflected due to the pulmonary transit time in a decrease in the filling of the left ventricle during the expiratory phase. During expiration, there will be a reduction of the cardiac output of the left ventricle. Mechanical insufflation on the left ventricle causes a decrease in the preload, different from inspiration, as we saw before, and produces a slight reduction in the postload of the left ventricle. Having seen the pathophysiology and the physiology of cardiopulmonary interactions with positive pressure, what happens when we try to wean the patient from mechanical ventilation, and therefore the patient begins to have spontaneous inspiratory effort? This is the situation in which there is a decrease in intrathoracic pressure. The patient will experience increased adrenergic tone, increased oxygen consumption, a reduction in partial oxygen pressure, and increased CO2 pressure, and increased respiratory work. This decreased intrathoracic pressure will determine an increase in the postload of the left ventricle, and also an increase in the systemic venous return. On the other hand, the adrenergic tone will also have consequences on the left ventricle afterload. It will be increased in venous return, and will also favor myocardial ischemia. The other three factors we have been discussing also have a consequence on venous return, pulmonary vascular resistance, and myocardial ischemia. And finally, respiratory work will be another factor that favors myocardial ischemia. These three elements combined will have consequences. The increase in venous return will cause an increase in the preload of the left ventricle. And the increased pulmonary resistance and the increase in venous return will determine a dilatation of the right ventricle because of the biventricular dependency. And finally, Together with myocardial ischemia, this dilatation of the right ventricle will determine a decreased compliance of the right ventricle. The increase afterload and preload of the left ventricle, as less as a reduction in left ventricle compliance, will result in an increase at the end of diastole of the left ventricle, and this factor will be very important in terms of WIPO. Pulmonary edema induced by weaning. This is one of the main causes of failed weaning based on cardiopulmonary interactions when weaning from mechanical ventilation. As Patricia mentioned, the patients at higher risk to develop WIPO are patients with heart disease of any etiology, pulmonary obstructive heart disease, and obese patients. When we start weaning, we can choose one or other strategy to prepare for extubation. Up to now, the studies have not shown any superiority of the D-tube test versus the ventilation with support pressure. However, the TPEACE trial leads to higher effort for the body on the respiratory system and the circulatory system at the time in which we do the spontaneous ventilation test. Patients at higher risk of developing WIPO have to do more effort in this case, and it has been seen that the TPEACE trial may assess this with more sensitivity when assessing tolerance to not having any ventilatory support. So in these cases, the literature recommends using the TPEACE trial as a stronger trial for extubation. The mechanisms involved in WIPO are multifactorial. We have spoken about increase of filling pressure of the left ventricle during the spontaneous ventilation test. The main mechanisms involved are hypervolemia and positive water balance. These are the most frequent causes, but not the only ones. WIPO, as Patricia already mentioned, usually occurs during the first 5 to 10 minutes upon weaning from the ventilator. And this differentiates from other causes of failed extubation, such as neurological or respiratory causes. On the other hand, although classically the WIPO diagnosis has been made by measuring pressure in the cardiac cavities through cardiac catheterization with a pulmonary artery catheter. Currently, echocardiography is very useful. It's a tool available at the bedside, which we can easily use. It's a non-invasive method. And patients at high risk of developing WIPO have an increase in the prime ratio, reduction in the left ventricle ejection fraction, and diastolic dysfunction. Hypervolemia and the positive hydric valence are not the only causes for failed extubation. Echocardiography is an important image. Mitral insufficiency or a dynamic insufficiency because of an anomalous septal movement may be one cause that triggers WIPO, and we are not able to identify just with the pulmonary artery catheterization. That's why we need complementary testing, such as echocardiography. In patients with previous respiratory disease, such as pulmonary obstruction, they may show alterations in feeling due to interventricular insufficiency or regurgitation. so we can focus an individualized therapy to the patient we want to extubate. In this case, let me give you a practical example. This is an example of one of the articles, recent articles of Philippe Villon. He suggests, in the case of his patient, a T-piece test to prepare the patient with an echocardiography, transesophageal echocardiography. This patient failed to the T-piece test. The patient is sedated again, and when the transesophageal echocardiography was performed, the transmitral speeds are increased. The E wave is 100 and the mean of the prime is 17. So these are increased rates. In this case, the decision was made to treat the patient. In addition to the high speeds, the patient developed hypertension. The reason why the patient was admitted was ventricular dysfunction of an ischemic etiology. The patient is taking vasodilators and diuretics, and after treatment, a new echocardiography was performed. With the new measurements, the speeds have been reduced as compared to the original rates when the first T-tube test failed. And with these new speeds measured with the optimized therapy, a new spontaneous ventilation test was performed, a T-tube test. After that time, the patient improved in the transmitral rates or speeds, and the patient fulfilled the T-piece test. At the end of the T-piece test, the speeds were measured again with no significant change. So that means there is no an excessive increase of the filling pressure of the left ventricle. The patient was extubated. This is an example. We're using echocardiography during a spontaneous ventilation. We can use the patient therapy to optimize the patient before extubation. So, as we approach the end of my presentation, which are the algorithms we can suggest to address the patient that we are trying to wean? When we start to consider weaning, first of all, we have to identify patients with a high risk of developing WIPO. The patients at higher risk are patients with an ejection fraction of the left ventricle below 40% and severe diastolic left ventricle dysfunction. Valvulopathy, particularly mitral regurgitation, patients that do not depend on preload, and patients with right ventricle dilatation with systemic venous congestion, whether they have pulmonary hypertension or not. So we have identified the high-risk patients to adjust the antihypertensive therapy, and we have to be careful with fluid therapy. Before the spontaneous ventilation test, be it with a T-piece or support pressure, we can adjust the therapy to improve the success rate of the T-piece test. And before doing the spontaneous ventilation test, once again, we have to assess the systolic function of the left ventricle as well as the diastolic function. And we insist on the importance of the presence of mitral regurgitation, deviations in the right ventricle and the right functioning. We can also measure the pulmonary artery systolic pressure and a preload dependency test.
So we can optimize this therapy and prepare the patient for the next test. Once the spontaneous ventilation test has been done, and if the patient has been diagnosed with WIPO, we have to try to identify the cause. And once the cause has been identified, to give the corresponding therapy. As soon as we confirm our treatment strategy, we can prepare for the success of the TP's test. But we have to compare, as we have seen before, we need to compare the parameters before the spontaneous ventilation test and afterwards. If this diagnosis is confirmed and there's an increase in filling pressures of the left ventricle, we have to identify the mechanism that has led to this. If we passed the TP's test or the support pressure test, if the test has been successful, we need to try to assess the relevance of the increase of the pressures in the left ventricle or the volume of mitral regurgitation if it's present. We can assess if you can suspend diuretics. Based on the scenario in which we are in, if it's and based on the etiology of WIPO, we assess diuretics, vasodilators if the patient has hypertension, or if they have abnormal movement of the septum that could generate mitral regurgitation, we can assess beta blockers. On the other side, and I have added inotropic medications do not improve the results of the spontaneous ventilation test because they increase myocardial consumption of oxygen. And on the other hand, because in studies, they have not shown improvement of the outcomes. However, levansimendin has shown to reduce filling pressures when it is used to avoid a spontaneous ventilation test. And finally, if despite all of this, they decided to extubate the patient, and once again, this extubation has failed, and even so we have diagnosed the patient from WIPO, we can continue to do something else. We can still try to optimize the therapy. We have to go back to a comparison of the measurements. We have to have measures before extubation and after extubation, either by echocardiogram or catheterization of the pulmonary artery, and insisting on what we mentioned before, confirm the diagnosis, and identify the mechanism that caused it. So conclusions that we can reach after this presentation are that spontaneous respiration or breathing can unchain WIPO, pulmonary edema induced by the weaning because of overload of the cardiorespiratory factor, even though tests that have been used for measurement of pressures have been pulmonary artery catheterization, echocardiography that detects high-risk patients and can guide us in the optimization of the patient and to improve the outcomes in the spontaneous ventilation test. And so far, there are no studies or trials that can give us a clear indication, and we require more trials to assess the impact of extubation on patients' outcomes. Thank you for your attention. Thank you, Ana Maria. Now we have Dr. Carlos Subira from Sao Paulo and Barcelona, who will talk about the new things during weaning. Carlos. Good evening to all. I don't know if you can hear me correctly. I'm going to share my screen, and I wanted to thank the organizers for this wonderful journey. We will update what is new in terms of weaning. These are my disclosures. And the first thing that I would like to start with is that to understand what weaning is, I will try not to repeat things that have been mentioned before, but in my opinion, weaning includes 4 points that are important. One is screening, the weaning criteria to correctly identify if it's a patient that could go through the weaning of mechanical ventilation. The second one is to verify that the patients that are prepared to breathe alone, to have them breathing alone and do a spontaneous breathing test, and the third one, which is the extubation maneuver. And lastly, a set of treatments that have been spoken about that are focused on trying to reduce the failure of extubation. And all of this ends up on weaning success. The patient will be relieved from mechanical ventilation or weaning failure to be able to have restoration of mechanical ventilation. Why is this important? I have mentioned before, because patients that need to go back to mechanical ventilation reintubation are patients that will have a higher incidence of pneumonia infections, will spend more days in the ICU, and will die more. And in fact, despite the fact that reintubation rates have been relatively stable, around 10 to 20% according to the series, the mortality of these patients that require reintubation is between 30 and 50%, which is quite important. Let's go to weaning cases. WeanSafe was useful to look at the cases of weaning around the world. Patients that spent more than 48 hours in mechanical intubation. 23% of these patients never started a weaning process. 12% started a weaning process, but are not released from mechanical ventilation, and 65% end up being released from mechanical ventilation in a successful way. And let's identify which patients could start the weaning process. If we go to the classical weaning criteria, the gold criteria, we have clinical criteria, basically adequate cough, absence of excessive secretions, the reason that caused intubation is controlled or solved, and some objective measurements, hemodynamic stability, oxygenation, correct oxygenation, CO2 under 8, the adequate pulmonary function, and the normal level of awareness. When the patient meets those criteria, we determine that the patient is ready to start the weaning process, and we should do a spontaneous ventilation test. But in the WeanSafe, they propose modifying these weaning criteria to define which patients were prepared to start the weaning process. And there are extubation and weaning criteria. Weaning criteria, FiO2 under 0.5, PEEP under 10, no doses of vasopressors, and no muscular blockers. And the level of consciousness is another criteria for extubation. And the author said that the level of consciousness in itself was not an alternative for patients to breathe, but for extubation, because we can agree that excessive sedation prolongs mechanical ventilation and the weaning process, but we still don't have enough evidence to say that we can start the weaning process in patients that are not prepared to be extubated, and this includes that low level. And these more conservative and aggressive criteria were studied by Gonzalo Hernandez in this article, and he randomized patients in FiO2 to 0.5, PEEP on 10, F ratio 180 versus more conservative screening. FiO4, PEEP 8, PF over 150. The first thing that they saw is that reintubation rates and aggressive screening were very, very similar versus the other. And post-extubation respiratory failure were also similar. But time to extubation was longer in patients that where we had been more conservative in comparison to the more aggressive screening. Now we have identified our patients correctly. We have done the screening, so we're going to test if our breathing is able to breathe alone. Every how often do we have to have patients breathing alone? Every how often do we do spontaneous respiration tests? We have to do it at least once a day, because what this does is reduce the duration of the weaning. We have to do it more. Do we have to do it more than once? In this clinical trial that was published recently, they randomized patients to a single spontaneous ventilation test plus more than one, and doing more spontaneous respiration tests not only increased weaning, but it extended it. Doing it only once is enough. And let's look at the controversy. What's the best technique? Is there one technique that is better than the other one? The previous speaker has been speaking a lot about this. And in fact, in some people, If you look at the physiology, we know that respiratory work that we do when we breathe before sport with PEEP is lower than respiratory stress when you do respiration without PEEP, and it's better than when we use the TPs. Respiratory work with the TPs is almost the same than that of extubation. And in this meta-analysis, where they included trials that looked at respiratory work and different spontaneous respiration tests, the spontaneous breathing test are better than the TPs. So possibly the best spontaneous breathing test is the one that mimics the situation in which the patient is in after extubation, though non-assisted people 0 or equal to extubation. But let's go to the clinical trials to see what we find. The first clinical trial that compares extubation, spontaneous breathing versus T-tube or pressure support. What they saw is that spontaneous breathing test with pressure support extubated more patients, 86% versus 78%. However, the main outcome of extubation success did not have significant differences. More recently, in 2019, we had a clinical trial with what we did. We compared two spontaneous breathing tests that are opposite. One that is very demanding, TPs 2 hours, and very little demanding pressure support during 30 minutes. And what the Dr. Ioan saw is the same thing we see here. When we do spontaneous breathing, we extubate more patients than when we do the spontaneous with the TPs during 2 hours, and the rate of reintubation of the two groups was very similar at 72 hours. So the primary outcome that was success to extubation at 72 hours was superior to spontaneous breathing. And in the TIL study, they replicated this only in patients that were high risk according to the TIL criteria, older than 65 years with chronic respiratory or heart disease, chronic heart disease. They did all the spontaneous breathing tests the same way, the TPs or pressure support. And what they saw is that the primary outcome, which is the days free of mechanical ventilation at 28 days, they didn't see any significant differences between the two groups. However, when they went to the secondary outcomes, the incidence of simple weaning was greater when they used spontaneous breathing tests and pressure support than when they did a TPs. And prolonged weaning was more frequent when they did all of the spontaneous breathing tests with the TPs than with pressure support. And the probability of being extubated before 7 days was greater with spontaneous breathing tests and with pressure support than the TPs. And in fact, the last meta-analysis that compares all of these clinical trials, comparing extubation and pressure support and TPs, the spontaneous breathing test with pressure support has better results than spontaneous breathing with the TPs. We did spontaneous breathing tests. What do we do now? We will let our patients rest, and letting our patients rest, you probably know this article from Dr. Fernandez that randomized the patient that had tolerated spontaneous breathing tests to direct extubation versus connecting 1 hour to the ventilator. And reconnecting patients to the ventilator reduced extubation failure and reduced the rate of reintubation. And there are two explanations. One is that that patient was allowed to rest, and the other thing is that we did some alveolar recruitment after the spontaneous breathing test. And in terms of the extubation maneuver that we have not given enough importance to, this group from Argentina asked if there were differences between an extubation maneuver with continuous suction when they did the maneuver or maintaining a positive pressure in the ventilator. In the safety study, they saw that at least extubating patients maintaining a positive pressure in the ventilator was as safe as extubating patients with continuous suction. And a short while ago, we have launched a study where what we do is assess if a weaning technique in the spontaneous breathing test and the extubation maneuver trying to preserve the pulmonary volume during the entire process as support of 8 and 5, as spontaneous breathing tests and extubating patients with a positive pressure could have better outcomes than the standard of care. That would be 30 minutes of pressure support at PEEP of 0 and extubation. And what we found, as has been presented at some congresses, but it's still not published, is that there are no significant differences between the two groups in terms of extubation success rates, trying to preserve the pulmonary volume. And once we have extubated the patients, we start the prophylactic treatment. Andres has been, Patricia has been talking about with high flow nasal cannula and non-invasive ventilation. So with low risk patients, we use high flow in comparison to conventional oxygen, reduces the need for reintubation. And basically because the reason for reintubation of patients when we use high flow is the wrong management. High flow helps us better manage the patient. And when we compare high-risk patients with high flow nasal cannula versus non-invasive ventilation, there were no differences between the groups. But Arnoldo Hill did a second trial asking why compare one against the other? Why not do something combined, high flow versus non-invasive, alternating with high flow? And what he achieved is that the high-risk patients that had high non-invasive ventilation alternating with high flow had lower need for reintubation than the patients where they only used high flow nasal cannulas. And this difference was very important in hyperbaric patients, as you can see. Second scenario, are patients that do not tolerate the spontaneous breathing test, and we need to know what to do. We continue testing spontaneous breathing. And the longer the weaning, we can classify the weaning as simple weaning. We extubate patients before 24 hours. Weaning between day 1 and day 7, and prolonged weaning more than 7 days of an attempt to wean after the first spontaneous breathing test. And this is relevant because the longer weaning time, the higher mortality. And one last thing on how to do weaning around the world. How the spontaneous breathing tests are carried out, an observational trial, 1,500 patients, 142 ICUs in the world. Up to 28% of the patients are extubated without spontaneous breathing test. 10% go directly to tracheostomy, and 62% are extubated with spontaneous breathing tests. And I know that there's an ongoing clinical trial in which very low-risk patients will be randomized to direct extubation versus spontaneous breathing test before extubation. And let's go to the next step. We have spoken of weaning, but can we do anything before the weaning to prepare patients? Well, we're just talking about what they call the switching phase. I look for the step before the patient is prepared to start the weaning process. And with the WinSafe data and observational trial, they had an emulation of a randomized clinical trial. Patients looked, if the patient had a PUFFY over 150 without muscle blockers, they considered that the patient could go to assisted, and they randomized patients to an early switching to start before 24 hours versus delayed switching, which is to start assisted modalities beyond 24 hours. And what they saw is that the patients that went to the assisted modalities or the pressure support achieved a higher success rate to extubation. And to end, my recommendations is that the weaning process should have a protocol. Weaning is not an art, and we have to clear out all the steps. We need the correct screening, probably more aggressive than what we have done so far, that we have to look at the spontaneous breathing test, know that unassisted pressure tests are more physiologic, but the evidence suggests that pressure support has better clinical results, that we have to stage the risk of patients to apply treatments that help us reduce the incidence of reintubation, and that we have to think about the extubation maneuver for our patients. And in terms of future research, we have to start to think about how to prepare our patients before reaching the weaning stage. And that was it. Thank you very much. Thank you, Carles. We have 5 or 10 minutes for questions. And I still don't see any questions on the chat. Can I ask Patricia a question? Of course. Come on. First, congratulations for your work with all of the predictive models. My question is, of course, all predictive models include variables that come in with the patient when they come to the spontaneous breathing test. Have you included physiological variables of the SBT, tidal volumes, constants, clinical constants that help us during the spontaneous breathing test so that we can identify that the patient has a high risk of failure? That's a very good question, because in fact, one of the things that we need to do to assess a spontaneous breathing test is to be there. It seems that the gases that you take out when the 30 minutes are over after the test, but it's to look at the interaction, because when the patient starts to claudicate, the respiratory frequency is increased, and that's a sign of the fact that the test is failing. We don't include them as specific aspects of the test, but because the tests that we do in these trials, all of them were seen directly and standardized. The way to assess the test as approved or failed. We didn't gather variables of the test because during the test, we were looking visually at all of that. So the 11-factor model, one of the items that scored was the fact of having failed at least one spontaneous breathing test for that same reason. It's the same thing you're mentioning. Perfect. We have a question in the chat from Ayagar. What is the role of levosimendan to reach a successful weaning? I imagine that that is more for Ana Maria, but any of you can answer. That is truly not a mystery, levosimendan. In one of the trials in patients with systolic dysfunction of the left ventricle, they use levosimendan to improve the filling pressure of the left ventricle before the spontaneous extubation test, and they saw that it improved the rates of extubation because of the dilator effect of levosimendan and the hemodynamic optimization before extubation. Thank you. I think that was a good answer. We have another question, which is if the use of the high flow cannula has exceeded the use of non-invasive ventilation post-extubation. I think that Carla and Patricia can talk about this. Patricia, do you want to start? Well, it all depends on the risk. Of course, to say that it has been better or not, I would say it depends. What patient, what group of patients? In patients with low risk, as Carlos was mentioning, well, high flow works really well. Why add a non-invasive? But in high-risk patients, it's not that one is better than the other. That was the trial, the TIL trial. It's that non-invasive versus rest with high flow is better than non-invasive alone. So more than the fact of thinking about one strategy being better than the other, it's one strategy for what risk group. It depends on whether the low is low, intermediate, high, or very high. That is the way I understand this. Carlos, anything else? Or are you satisfied with what Patricia is saying? And Patricia, these patients where you have started prophylaxis with high flow, what do you think about escalating to non-invasive ventilation? Because you don't see that the patient is completely well. Well, I would love to look at the Ventilo trial. It will be very interesting, which is precisely that knowledge gap we have on whether you can treat post-extubation failure or not, because it's one of the things that is scary. If I delay reintubation, I increase mortality. Well, but there are patients that benefit from that strategy precisely of escalating high flow to non-invasive and do a very short monitored trial. So I think that the Ventilo trial will be fundamental to be able to answer this question. Perfect. I think we can add, Anna, if failure of extubation because of heart failure, would non-invasive or high flow be better in that situation? I didn't hear the question. Well, that Luis Lopez's question was not oriented to that, but you mentioned one group in particular of patients. If heart failure or the failure of extubation is more related to heart failure, the WIPO, what can you say about that? High flow or non-invasive ventilation? I would say non-invasive ventilation because that is what has shown to improve things. High flow, well, if you don't have non-invasive alternatives, we could use it, but there are no studies that show that they improve results. Well, I think we are right on time. We want to thank the organizers again, and I thank the speakers for their generosity, and especially at this very difficult hour in Spain, very late hour. I personally have enjoyed the session and the presentations, and we hope we're invited next year to the Critical Lung Day. And we will see you later, and thank you. Thank you.